All right. Good morning, afternoon. I guess it is, everyone. Pleasure to be here with all of you. I'm Dr. John Milne. I'm the Senior Vice President for Real Estate Strategy and Operations for Providence St. Joseph Health. And joining me in our conversation today is Aaron Couch, who's our Director for Architectural Standards and Design here at Providence. And we're going to jump into some discussions about COVID design in the our design standards and architectural design here in the post-COVID era. But before we do that, the disclaimer for all of us is, even though I am a physician, please no medical questions. If you have any medical issues, please reach out to your primary care physician or a health professional in your community. And that the information today is really being provided during this for informational purposes. And so again, consult a professional if you've got any questions about how to actually design clinics and what types of standards look like there. Please make sure that you touch base with a licensed architect in your community who can be able to advise you appropriately. So with that, Aaron and I are going to jump into really kind of an ongoing conversation here about what does it look like for healthcare design in the post-COVID era. Would welcome your comments in the chat box. So if you've got those in the various windows, those are going to be forwarded on to us. And I think, given the interface, we're going to be able to see them okay, and we'll try to respond to them as we move forward. So if you've got questions, please feel free to enter them into the chat. But we're going to have hopefully a fun conversation here over the next hour or so. And again, welcome the participation. So Aaron, welcome to this conversation. This is as we kick off the new year here, starting to look into what does the future look like and reflect on what was 2020. Wanted to just give you a few minutes to introduce yourself and tell us a little bit about your background, how you came to Providence and your professional journey, and then just your reflections as we start into this of what do you see as you look at the future of how does COVID inform the future of architecture and design, both within the healthcare space. And I'm just curious in general, as we think about our broader communities, I'm sure that we may have some architects and designers and developers who are in non-healthcare spaces, but certainly are worried about how do we think about the world from a design perspective. I'm just curious your insights. So Aaron, I'll hand it off to you.
Well, John, that's a whole lot of stuff to discuss. Thank you. And oh, by the way, before we start, I have this pain in my shoulder. Can I ask you about that? No? Okay.
You sure can. Right. You want to just, can you do this?
No, I do not. I did read that disclaimer. So thanks, John. Yeah. Hi, everyone. I'm Aaron Couch. I am the Architectural Standards and Design Director for Providence. I'm also a healthcare architect. I'm registered here in the state of Oregon. And in my role, I serve four functions, if you will. My first function is actually I am the standards bearer. I handle all of our standards, and so far we have 4. We're probably going to be adding 2 more. And within those standards, there are brand standards, and then there are, as John likes to call them, more guidelines. Those are some of our products. The second thing I do is I advise on design for any project that's over $2 million, which turns out to be just about every project we do around here. My third responsibility here is I'm a member of the Planning Council, and we offer strategic advice to executives across all of our regions. And I work with a great group of very smart people. And the last bucket, which is, it's kind of the catch-all, but I interface with our flooring and furniture vendor partners and strive to bring products to our built environments that are at a price point that reflects the quantity and quality of the projects that we have. I also do a lot of programming. I do a lot of code checking. I've helped on housing projects over the year. Got to advise on a painting project for the Emily Gamlin House here on Halsey Street here in Portland. And I have been known to answer the obscure question or two about architects. So that's kind of my role here at Providence. I've been here about 5.5 years.
And before that, you were a healthcare architect. I mean, you've been out in the real world and done architecture for real. Unlike being an armchair architect and wannabe, is what you're saying.
Thank you, John. Thank you. Yes, a real registered architect. That's how you get to be called an architect, by the way. You actually take the exam and get registered, just so we're clear. I have to say that for my architectural brethren listening in. So my journey I think the thing that really impacts my job here is because I was 30 years on the architecture side of the fence, right? And same with my colleagues on the Planning Council. We were all in those roles. We had to put budgets together. We had to make deliverables. We had to interface with clients. We had to get real-time solutions to problems. And we are very used to delivering products in that manner. So 30 years, that's a long time. Yeah, you can figure out my age from that. But the advice I would give to anyone who's on my architectural brethren on the other side of the fence is that, first of all, I appreciate all the work you do for our system. We have fantastic partners, and they keep me on track too when I get involved in projects. But more to it, I can speak the language of an architect to our caregivers who may or may not ever have been involved in a design project before. And I find real value to that. Everybody wants to do a design project, John. Everybody wants to build that tower or the clinic, and everybody's got great ideas. But my role also happens to be to kind of, pat down those wants and needs with kind of reality and help ease the way for our architecture partners when they want to do great built environments for us.
So I think, as we look at this, obviously the focus of this conversation is somewhat going to be the future, but we probably should start by taking a couple of minutes to look at, what our initial response was. And so, as you reflect back on, the first COVID patients in the United States were about a year ago, a little over a year ago now, and we began really seeing the ramp up, and as a system, really we're on the leading edge of the country in terms of trying to respond to the broader pandemic, because the first COVID patient in the country was actually at Providence Everett, one of our hospitals there. So in some ways, we were really trying to develop the playbook, literally the playbook at times, for across the system of what it looks like. And so you want to share a little bit about your experience as you think about what were we looking at as a system early on in those early days of March, April of last year, to think about how did we respond to this from a design perspective and a facilities perspective?
Absolutely, John. I like to refer to that first phase as the sheer panic mode phase, which really was January to, let's say, the end of April. I mean, sheer panic, right? None of us knew what was coming at us. We're all problem solvers here at Providence. And I was thinking about this in preparation for this. The masking requirement wasn't even in place. So our biggest challenge was to make sure anybody sneezing or coughing, that we could prevent these droplets from hitting our caregivers, admitting people. So remember the rush of plexiglass protection. And I even had to go on, everybody went to Amazon first, right? Well, that turned out to be not helpful after a while. But I was looking at things like acoustical barriers made out of acrylic that drummers use. We were just thinking of anything. And then we transferred very quickly to, what are we going to do with all these people that are going to be at our hospitals? So what did we do? We looked at converting warehouse space, futsal, indoor soccer spaces. We looked at hotels, convention centers. We were even doing layouts here at POP 2 about how many people we could fit into this building in case of emergency. And they were at first.
And just for those of you who aren't familiar with POP 2, at our office building, our kind of main administrative office building in the Portland market for Providence. So.
Right. Yes. Thank you, John. Sorry about that. And then, of course, the whole hoteling idea, converting those spaces, and then. Everybody kind of started to understand what was happening out with COVID, and the strategies kind of started to kind of get tighter. And that's when the playbook started. That's when we started doing the social distancing that our European brothers and sisters were already kind of ahead of the curve on that. That's when we started looking at 2-foot-high partitions. Again, a lot of these ideas were, of course, checked and reviewed by Becca Bartels, who's the head of our infection prevention. Lots of stickers showing up, right? So phase 2 is the sticker stage, right? Or the more moderate.
We're looking at a lot of the HVAC systems and thinking about what airflow looks like
absolutely
in these spaces and negative pressure. And you want to talk a little bit some of the challenges we had to look at of how do we retrofit existing spaces with regard to some of that and the design challenges.
And thank goodness for Dave Thompson, my colleague, because he was the brains behind a lot of that, working with our facilities directors at our ministries across the regions, because really everybody was kind of going at this on their own as they needed it. The playbook was really more for the clinics. Yeah, maybe there were some acute care recommendations, but the hospitals got very good with their facilities people on how to adapt their HVAC systems. I saw all manner of examples coming back at me, thanks to Dave sending me some pictures. And I just applaud the ingenuity of our facilities people and frankly, our caregivers, right? The caregivers who came up with systems on how to put their PPE in such a manner that it didn't get infected, even a simple paper bag to put things away in. I mean, all kinds of just kind of homegrown, as you needed it solutions. They didn't need an architect weighing in on that. They figured this stuff out on their own. But the HVAC solutions are more challenging. It started with maybe just a controls issue. Maybe you just got 100% outside air, and then you started seeing solutions like taped flex duct going out to a window for more severe instances, doubling up on patient rooms. And those last surge. So that was kind of phase 2, right? We're learning all this stuff. But phase 3, we all thought we were going to kind of take a breather on phase 3 and kind of
And John, here comes the next wave before we knew it.
Nope. I mean, so we just really, the advice was just stay home, just stay there. The solutions that were already in play were just getting hammered, but they were in play and they've worked to date. So that's kind of the last year in the review.
So I guess as you think about that, as you reflect on it, I'm curious, you've obviously spent a large portion of your career pre-COVID designing hospitals, thinking about what the acute care standards for Providence need to look like, and developing those. What has changed now that you've lived through 2020? If you're going back through and rethinking the way you used to think as an architect prior to this, and to think about the standards that you developed for the organization, what's different now? What are the things that you would change about the way you've always kind of thought about architecture going forward for a hospital?
That's a great question, because 30 years of institutional knowledge, right, completely dissolved within 1 year of a pandemic, right? Well, not all dissolved, right?
Yeah. At least changed and modified. So what are the modifications in your mind?
Yeah. So interestingly enough, on the acute care standards, so one of our ministries, St. Vincent Hospital, actually was in the process of building the ICU, which is based on our template. And there's nothing they would change about that, because the care is outside of the room, obviously, as critical care or intensive care needs to be. But the rooms are large enough and enough space in there that there's room for the equipment. There's room for people to move around without getting close to each other. So that's actually been a really great plus. The standard actually also included a pass-through at the wall, separating corridor from room. So that was the intent of the standard, is that people would never go into the room that didn't have to go in, that supplies would be handled from the outside, as well as trash removal and dirty linens, et cetera. Now, St. Vincent's didn't use that, but that's part of the standard. So that's just a simple example of how the acute care standards probably wouldn't change. But the standards in general on the clinic side, there's absolutely things we're going to be looking at as we go forward in this COVID environment. Lessons learned. The truth of it is, John, we're probably not going to deploy any of our COVID strategies in the built environment, because by the time we re-engage our built work, COVID will be behind us.
Yeah, I think, though, the thing I would say is that kind of reinforce a couple of lessons learned. The things that we knew ahead of time going into it, but I think has really been reinforced is flexibility. I mean, we've all had discussions about acuity adaptable rooms and being able to have the ability to move between different levels of care. And I think a lot of those sorts of design concepts of we don't know what the future is going to look like necessarily, with whether it be with care delivery or when the next pandemic is coming. And I think a lot of the flexibility that we were already starting to design into our spaces just proved a lot of value in this going forward.
Absolutely, John. Flexibility. I mean, we talk about it in the industry all the time, and everyone says, make everything flexible. Okay, that's a challenge. Okay, any architect, any designer will tell you, making a space flexible in the healthcare arena, yeah, good luck. So here's a couple lessons I have learned about flexibility. One is we have to stop doing the custom work, right? We have to make our rooms as standard, dare I say it, as possible, because when you standardize a room, And it goes across the system. Not only are you promoting best practices, which is really the genesis of our standards, by the way. It wasn't to make the architecture easy. It was to promote best practices for our patients from our caregivers, so that a room in Alaska would be exactly the same room as somebody in California, and you didn't have to rethink how you were servicing a patient in those rooms. That said, is there room for change and better development? Absolutely. The flexibility, I think, is going to come in a size that generally works for as flexible a space as you can make it without breaking the bank, right? Because we always have to balance that huge square footage against the cost of construction. Do I think our standard room now could hold 2 patients pretty readily? Yeah, I do. And in fact, if we want to go to a universally adaptive room, I think we have one already. It's our ICU room, right? So don't make it ICU, it's our room for everything.
Mm-hmm.
But then the ministry is going to have to, any of us who are in this design discussion have to say to ourselves, well, is that the best use of our funds? If Dave Thompson were here, he'd say, well, he's going to be asked about, can you make one head wall adapt to 2 patients, right? But that has implications on the gas and the vacuum and the medical section, all of it, right? So just to say flexible, you kind of just lift the lid a little bit and say, whoo, that's a tough word to kind of manage around. But I do think standardization of size of space, standardization of where things are in the room, simple stuff, and then adapt it as you need throughout our system, and any healthcare system has the same idea. I think that's going to buy us a lot of preparation for the next whatever comes at us. We've been talking a lot about the acute care environment, though, John. So much of our work is on the clinic and ambulatory care side, too. I do think that we're going to be very mindful about how we enter and exit our buildings. I think we're going to have more queuing areas, more vestibules, the ability to stop a patient from coming in, not to stop them, but just to say, hey, wait, can we take your temperature? Can we, whatever the next pandemic makes us do. I also think that there's going to be a very careful backdoor exiting that allows caregivers to go out to a car. You yourself came up with a great idea about why don't we look at other ways to triage patients without even coming into the building. These are really great creative ideas that I think we need to pursue further. I do think that we're going to be very mindful about how much that we're going to isolate rooms that can be exhaust air. I think that's going to just be a go-to. I don't think we can avoid it. And hands-free door operation, paper towel dispensation, soap dispensation, water, all those are going to be very important going forward. And not only is that just great from, a no touch, it's also super easy, right? When you're a mom with kids, or excuse me, a dad or mom with kids, or you're helping your elderly mother with her walker, and just being able to push a push plate is so much easier. So, what solves for a pandemic also solves for a whole other host of design issues that we find ourselves in.
Yeah, I think that's an important point. I think, backing up all the details that you're talking about there, to my eye, in some ways, what COVID has been is the 9/11 moment for us in healthcare. Is, we've had near misses my entire career, and so for those of you who don't know, I'm an emergency physician by background, and so I've been practicing emergency medicine for over 20 years now, and is something where, with SARS and MERS and Zika virus and Ebola, I mean, there was always this looming risk of infectious disease that never really truly manifested itself into a global pandemic the way COVID has. But it was always there. And we always, kind of felt like, kind of big sigh of relief didn't actually happen. And thankfully, and now we went back to business as usual. I think this is going to be a sea change for us that I don't think we're going to go back to business as usual once this is done. And I think a lot of the design principles that you're talking about how do we more efficiently triage people who are coming into our buildings? How do we think about, how do we segregate the sick population from the well population in a more effective way? Recognizing the risks that associate with our processes are an ongoing, element there that we are may or may not be seeing in this process that really are going to kind of continue to transform how we think about the built environment. So I guess
absolutely, John. The built environment, as we know it in however many years, is not going to look like the built environment we see now. I mean, between the technology that we're even experiencing within Providence, the idea about, housing is health, right? You and I have spoken about this a lot of times, that the hospital of the future and healthcare of the future may just be the house that you live in is going to be where you get most of your care. And how does that affect the built environment as we look forward? Because I truly believe, as you do, that we cannot keep relying on our hospital builds to make our communities healthy. That's not even the direction this health system wants to go, right? Mm-hmm. Yeah. So, I mean, we talk about social determinants of health and how that plays out in our hospital builds and our acute care or our clinic builds, but really what we need to focus on is how to make our communities healthier. And, we're not going to avoid a pandemic, but we certainly can make our communities healthier and perhaps more aware of themselves and their health, that they don't get us sick next time. I don't know. I'm not a clinician. I don't even play one on TV, but you are a clinician. So I think that there's some truth to that.
But I think, it's, and so one of the questions being raised here in the chat, I think is, interesting to for us to touch on here is, we're looking at these design changes, whether it was in terms of air changes and negative pressure flow and some of those other sorts of things. How is the Department of Health or Joint Commission or, any of our other regulatory bodies, or, whether it's OSHPD or whatnot, how do you see them, adapting to COVID and the process? I mean, many of the things we do in healthcare design are driven from a regulatory perspective.
Absolutely.
Do you see any places where those regulatory bodies that we have to respond to are starting to have the conversation of, we need to change the way we've got the rules in place going forward?
Well, that's a good question. And I would probably refer to any of our DCMs across our regions, because they're the ones who deal with the authorities having jurisdiction, especially. But I do know of the conversations I've had with our DCMs, that the authorities within the within this COVID envelope have been very, they've been both very adaptive with our partnerships and been, and cautious. I know it's tough for regulatory agencies to just, let's just do it. Let's just figure this out, and we safety be darned. But I think that I've seen a lot of adaptability from our authorities, and I think that's great, because their eyes are just as open as ours are. And I cannot speak to California, because California is definitely a place of its own. God bless you all, Californians. Love your OSHPD. But it's a challenging environment to design in, and we have a lot of experts who could speak far more intelligently to how we're going to move the dial in California. So.
Yeah, and I guess, and not specifically to California, I mean, I guess I would agree with you. I think it's really an ongoing dialogue, and I guess the thing that I'm encouraged by the early conversations we've had, with OSHPD here is being able to have a willingness to be at least open to some of the conversations that they may never have had before. And I think the same is going to be true with Department of Health in all of our states and the Joint Commission and other regulatory bodies, is that, we recognize that governments move slowly and that change is incremental oftentimes. But again, I think this has been a wake-up call for everyone across our various institutions and looking at what that is.
Yep.
One of the other questions that's popping up here in the chat is, talking, I think it's in, one of the things we've seen across COVID is the challenge of, we put a lot of patients into isolation, haven't allowed families to be present in the rooms. And, we've tried to use technology solutions with iPads and other things to try and help patients and their families stay connected when they need to be in an acute care environment. How do you see, more broadly, in the future, how do we keep families connected to the patients? And I think, what have we learned from this that may not be specifically around, isolation sorts of features, but I mean, are there lessons learned that we can extrapolate in a more broadly way of how do we allow, through the built environment, families to be more connected in these spaces?
Yeah, that's, boy. Ask me that question in 5 years, John, right? When we've got all this time to kind of focus on.
Yeah.
So here's the thing about COVID care. The patients generally on their stomachs, right? in most instances, the most severe cases. And that's already putting a patient in the worst place possible for any kind of communication, right? So do I think we're going to have, computers underneath stretchers? I don't know. I believe that you have to have the patient's families with them for the best care, but not in every instance, especially critical care, sadly, right? So I think what we're going to see is a lot more technology that enables that communication to happen more easily than it's had. And God bless our caregivers, again, across our system, who came up with these adaptations to allow families to at least be present, if not physically, through technology. I mean, you talked about how, government and agencies move slowly. Well, healthcare systems are on that, could be called the Titanic, just like the rest of them.
Exactly.
So the fact that they adapted so quickly to this situation is remarkable. So we have excellent IT people. We have great clinical engineering facility people. I would love to talk to them about, when this all settles down, it's like, what were the top 5 things that you learned about how do we communicate with our patients? Because this architect doesn't have a lot of eyes on that. I do know that we, of course, make our rooms large enough for patients to be, families to be in there, but that's not the question. The question is, how do we handle communication when that person-to-person ability to do that is not possible?
So in the last couple of minutes we have left, I'm just curious, what is, as you pull out your crystal ball and are looking, as you were talking, 5 years into the future, 10 years into the future, or designing the hospital of the future to a certain degree, what are the big, 2 or 3 big macro trends that you see coming out of our experience over the last year that really is going to transform design, maybe not just in the hospital, but in the broader community? Are there things, as we think about, commercial office space or, residential architectural design, as we live into what is health and designing for health as opposed to just health care? Are there any big predictions? I mean, and we're going to hold you to this. We're going to come back to you in 10 years, interview.
Oh, God, help me.
All of them were right.
I'll be retired by then, John. So go ahead and ask your worst of me. No, I truly believe, I'm probably not going to answer this because I want to answer this other big question. I think the best lesson, if that is a possibility with COVID, is that we all took a pause, right? I mean, no architect, contractor, designer, engineer wants to take a pause on building, but we did. We had to. And I think the thought leadership that came out of this pause within ourselves and, frankly, our architectural brethren out there is amazing. The things that people were able to stop and think about now that we aren't really, fast and furious building stuff. We've had this self-imposed thought leadership time. And the thing I've seen that I find just really engaging is that as we go forward, I do believe that there's going to be less and less health out there. It's going to be more in here within your own environment. I mean, I see the technology that endorses that. I see our own telehealth, statistics that say people would rather be at home for many of those discussions. I think that is I think 5 years from now, I could safely say that we are moving towards more in-home care for all of us, or other kinds of care, right? I mean, in-car care, who knew, right? I mean,
No, I think you're right on it. That is a macro trend that had been there before COVID, and I think is really just going to accelerate further as we're moving more and more care out of the hospital. The intensity of care that's happening in the hospital that's there, and you and I certainly aren't revolutionary in terms of suggesting that is what the future of care is delivered. But I think what this really has shown is how rapidly, as a health system, we can pivot to alternate processes. And, we've stood up tents. We're able to deliver care in alternate sites that we never thought we were able to do before. What can we actually do in the car? You and I have participated in a recent session around thinking about, what types of care can we provide without somebody even getting out of their car. And so across all of those, for us here at Providence within real estate, it's been I think a really interesting kind of conversation to think about what that means for the future going forward. So, Erin, any final thoughts before we kind of wrap up? We're kind of at the end of our time here together, unfortunately. And
that's okay, John. Just going to ask you, who's your favorite architect?
Who's my favorite architect? I mean, other than Erin Couch? Is that what we were talking about?
Oh, stop it.
I've got so many. I mean, I'm a big Gaudi fan. So Frank Lloyd Wright's on my list.
Oh.
And, how do you? I always mispronounce her name. What? Hadid.
Yes. The late great Zahida Haddad. Yes.
Yeah. So cool. She's probably my absolute favorite. If I were going to put those three kind of go onto my Mount Rushmore of architectural design. So
good to know that you have that information right at the ready, John. Appreciate that.
Yeah. So with that, I appreciate everyone tuning in for us today. Hopefully this has been somewhat entertaining for you. And hopefully you took no medical advice away from our conversations about architecture because, and so anyway, but thank you again for this topic. Thank you everyone for tuning in. And to learn more about Providence and our initiatives that are going forward and the programs, the ways we're able to serve our communities, I encourage everyone to go to providence.org for more information, and on social media, being able to follow us through the Providence Health System at LinkedIn, Facebook, Instagram, and on Twitter. So thanks to everyone for joining us today, and look forward to continuing the dialogue. So good luck. 2021. Thanks, Aaron. Appreciate it. Have a good day, everybody.